Good evening. I want to call the meeting to order, and if you'll join me in the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Catherine, if you could call the roll, please.
Director Nicholson.
Present.
Director Wallace.
Present.
Director Stewart.
Present.
Director Danielson.
Present.
Director Eaton.
Present. Thank you very much, Catherine. Nancy, we've got our educational session.
This is Nursing Week, National Nursing Week. And to do the introductions this evening, I've asked Jan Wood, our Senior Associate Administrator, who is an RN, to begin the program.
Good evening. As Nancy said, this is National Nurses Week. Am I coming through?
Yep.
Okay.
Loud and clear, Jen.
National Nurses Week, and we really take the opportunity this week to recognize our nurses and to thank them for all the hard work they do. I think the board remembers our journey that we made in 2011 for magnet status. That was a very complex and difficult job that we did, and we did very well. And so in 2011, Washington Hospital System was actually granted the magnet status in recognition from the American Nursing Credentialing Center, and that's the highest recognition that an organization can get for the quality of nursing care. So I'm going to move on and now present to you the program for tonight. And Stephanie Williams is going to be doing the program for us. And the name of the program is The Varied Fields of Nursing. And I'd like to go over Stephanie's bio with you. Stephanie's been at Washington for 14 years. She's a registered nurse with a master's degree in healthcare administration and a certified professional healthcare quality certification, and she's board certified in nursing executive administration. Stephanie is the current chief of patient care services. She has oversight for all the patient care services areas. Before she became the chief of patient care services, she was the chief of quality and resource management. During her time here, she's actually filled two very big positions in the hospital. Stephanie?
Good evening. Thank you, Jan. Thank you, Nancy. Thank you, board, for given me this opportunity this evening. One of the reasons we chose this topic is because nursing is truly a varied field. So tonight we're going to take you on that journey in terms of some of the fields that are available within our organization. As we mentioned, as Nancy mentioned, this is Nurses Week. It's May 6th through May 12th. And the American Nurses Association theme for this year is delivering quality and innovation in patient care. And you're probably asking, what is innovation? Innovation means different solution, being creative, a different way of thinking, a different way of doing things as the healthcare continues to evolve. Across America today, nurses use their knowledge, their compassion, and their skills to help patients maintain and improve their health, help them stay educated about their treatment, and to help them care for their bodies and minds throughout the lifespan. So this is through the whole continuum of care. Registered nurses uses innovation in processes, technology, and best practice to improve quality and patient care. It is reported that healthcare delivery system is becoming so complex that nursing is going to have to stay up with current and sophisticated technology, know the system of care out there, and able to ensure safe nursing practice. So our goal with innovation is to improve the quality of care as well as access to care. Provide a leadership role ensuring better patient outcome, that always comes first, and then using the data to compare performance, identify problems, and develop new care strategies to improve patient safety and outcomes. So join me. Let's celebrate nursing at Washington Hospital. As Jan mentioned, we are magnets. And studies have shown that better the educated nurse the better the patient outcomes. The Institute of Medicine have made a recommendation that by 2020, 80% of the nurses should at least have a baccalaureate degree. Right now, that current standard is 50%. Certification is another key role. This is from the professional's recognition of achievement, expertise, and clinical judgment, which validates the nurse's knowledge and increases the level of clinical competency. And again, professional organization. The nurses are keeping current in their specialty, and our nurses belong to at least 36 different professional organizations. And these were some of the qualifications that we needed for magnets. So let me take you through some of the results. Looking at education. This is educated nurses at Washington Hospital with a BSN or higher degree. And we are compared against Magnet. NQI is the national database for nursing quality initiatives. That is the best practice. That's the benchmark in terms of how nurses across the country compare themselves. There are about 1,900 hospitals currently today enrolled in NQI. And when you look at us in terms of critical care, we are higher than the benchmark. Let's take a look at MedSurg. Even for MedSurg, for quarter ending December, we were 74% of our nurses had BSN or higher degrees, compared to the Magnet organization of 46%. But remember, we were very innovative in terms of having a new grad program for years. And the new grad programs were nurses with BSN, many of them had master's degree. So this has been part of our culture for a very long time in terms of promoting higher education within our nursing structure. Let's take a look at certification. Again, we're going to compare ourselves against the best of the best out there as it relates to benchmark. And you see repeatedly our nurses are certified, a higher degree of our nurses are certified compared to best practice. And it's the same true for MedSurg as well. So there's a difference between critical care and the MedSurg area. But overall, when you put our numbers together, we are very much higher than the national average. A nurse role varies from staff nurse to nurse practitioner to educator or researcher. But no matter the role, each nurse practices with a commitment to patient safety. Nursing is a profession of varied interest, and our nurses work in different specialties. Let me be your guide through the varied field of nursing at Washington Hospital. We start with the CNR. She's responsible for clinical and staffing, and in terms of nurses functioning within their scope of practice. She's also responsible for ensuring that it's aligned with the mission, values, and vision of the organization. We have nurse leaders. Every clinical area, there is a nurse leader, and they are responsible for the day-to-day operation of their area, which includes quality, staffing, and budget. So here are some of our leaders. We have charge nurses, and oftentimes they're the ones that the patient first see when they get to the unit. These are shift-based. Every shift has a charge nurse. They have frontline responsibility for ensuring safe care on that particular shift. They're the ones that the patient seek out in terms of asking questions, so does the physicians. The nursing supervisor is responsible for overall day-to-day operation in the absence of nursing leadership. At Washington Hospital, we have nursing supervisors on the PM and night shifts, and on weekends at times. A nurse practitioner. In order to stay current and in order to adapt to the evolving complex healthcare delivery system, nurses are going to need to become more educated. We have nurse practitioner on staff, and these are nurses that have completed additional training beyond that of a registered nurse. They have had a master's degree, but they have gone on beyond that for additional training. And that could be in different specialties. It can be in cardiology, it can be in surgery, it can be in neuro. The clinical nurse specialists are also advanced practice registered nurses with graduate preparation. They work with other nurses to educate and assist them in advancing their nursing practice and improving patient outcomes. They are clinical. They are the ones that are at the bedside. They are the ones that are helping monitor. They are the ones that's teaching. So they are educators. And here are the group of them. I know many of you are very familiar with these staff. Let's take a look at the direct caregiver. Critical care, emergency. The emergency room is our front door. This is where the majority of our patients come through. So these are the nurses they see upon entry to the emergency room. Critical care is our intensive care area. These are some of the nurses that are part of that team. We have the medicine and surgery. We have nurse oncology navigator. I talked a little bit before about innovation. This is innovation. We were one of the first to adopt a nurse oncology navigator. This is a nurse that helps the patient go through the process of receiving medical treatment in a smooth manner. We talked about innovation, we talked about being creative. This is creativity. We have nurses in radiology, we have nurses in stroke. Again, this is being on the forefront. This is under the leadership of our CEO, Nancy Farber and Jan Wood, and with the direction from the board. This is innovation. Orthopedics, maternal child health, cardiac services, perioperative services. And many of these nurses are certified in their field. Many of those nurses belong to professional organizations. So on a day-to-day basis, they keep current with what's going on in their particular specialty. Let's talk a little bit about the non-direct caregiver, because oftentimes you see them around the hospital, don't know exactly what they do. Sometimes they are hidden behind closed doors. You don't have access to them. So let's talk a little bit about them. Bed management, they oversee all the daily admissions, the transfers and the discharges in the hospital. They try to balance the access for beds with the available beds. So they work as our gatekeepers in terms of making sure that patients are placed in the appropriate level of care. We have spiritual care nurse. This is a master's prepared nurse that went on and did an additional degree in spirituality. She's the bedside nurse, but this is something that she coordinates spiritual support to patients, family, and staff. Oftentimes, we have case management. They are all RNs. They assist with the transition from the hospital to the community. They are the liaison between the insurance companies and the hospital and the patients. Quality performance improvement. Oftentimes, we talk about our scorecard. How are we doing? And how we continuously looking to see how we can improve and do things better. Well, this is the group that helps us with that. They help us gather the information. They help us analyze the information. They look for trends so that action plan can be developed. They're the ones that on a monthly basis will give us that data that says this is how many infections you have. This is over time, this is what it looked like. So these are behind the closed doors that doing the ongoing monitoring in terms of our performance. This is how we check to see how we are doing. Infection control. They specialize in preventing and development the spread of infection. These are the nurses that are very much in touch with very specialized in terms of what they do, in terms of ensuring that the patient is safe. Informatics, as we embark upon an electronic healthcare records, nurses play a key role in that. There is an informatics section. Many of them are involved in EPIC, as well as some of the downstream systems associated with EPIC. And again, they use health information technology to improve patient safety, quality, and efficiency of healthcare. Employee health. They're responsible for worker safety. These are the nurses that look to see whether or not the nurse is safe to come back to work, whether or not there is a spread of infection among nurses. Again, the whole focus of everything we do here at Washington Hospital is to put the patient first in terms of first do no harm. Then we have the risk management and patient rep. And we see them as advocates. We all advocate for the patients, but this is truly their function in advocating for the patient. The patient rep works with patients and family to address any issues they may have. And the risk management is responsible for preventing harm to not just the patient, but also to the organization as well. So here are our staff as it relates to both employee health and risk management. Oops. As we celebrate the birthday of Florence Nightingale, the founder of modern nursing, I'm going to leave you with this. This is a quote from Florence Nightingale, and it's based on notes from nursing, what it is and what it's not. And the very first requirement in a hospital is that it should do the sick no harm. And it goes back to our mission and vision here at Washington Hospital, patient-centered, patient-first ethics. Thank you.
Thank you, Stephanie. Any questions for Stephanie?
Very
No.
impressive.
Yeah, no, I think we've got a very impressive nursing staff, and I feel very comfortable with my patients when they're in the hands of Washington nurses, because they do a great job. All right, we've got the consideration of the minutes from April 10th, 15th, 22nd, and 24th. Do I have a motion?
Move to approve?
Okay, is there a second? Second from Dr. Stewart. All in favor?
Aye.
Aye. Any opposed? Motion passes. Any oral communications from the audience? Catherine, do we have any cards? Then we will move on to written communications from Dr. Romano.
Thank you, Dr. Nicholson. I'd like to present the medical staff credentials action items for April 9th. We are recommending appointment and privileges for Dr. Shannon Crawford, neurointerventional radiology, Dr. Vachi Bezdikian in anesthesiology, Dr. Zach Martinez in anesthesiology, and Dr. Yassar Sharif in anesthesiology. We are recommending that you grant 2-year reappointments to the following physicians: Jeannie Ahn in nephrology, Albert Asali in urology, Khalid Baig, family medicine, Stacy Berry, OBGYN, Siobhan Calhoun, OBGYN, Gloria Carrion, internal medicine, Edmundo Davila, family medicine, Kevin Gersten, otolaryngology, Ashe Calais in orthopedics, Kimberly Kurtz, a physician assistant to Allied Health, Anna McNay, dermatologist in ambulatory status, Megan Nguyen, physician assistant to Allied Health, Keith Fleiger, a perfusionist, also in Allied Health, Ajit Sandhu, pulmonology, Benito Valencia Jr., internal medicine, and Edward Whalen, also in internal medicine. We are recommending that you grant 1-year reappointment for Dr. Surinder Sandhu in anesthesia. We are recommending non-reappointment for Jashri Acharya and Leila Alpers, both having deemed to have resigned. We are recommending that you transfer staff category for Dr. Daniel Gomes, a podiatrist, from active to retired, Dr. Asology from active to ambulatory, Dr. Evan Strong from nephrology from active to ambulatory, and Dr. Surinder Sandhu from active to courtesy. We are recommending that you extend both the proctorship and provisional category for Kiran Kapila, Yagya Kapila, and David Voon. And finally, there is one resignation, Dr. Marco Perez. That's my report.
Great, thank you very much, Dr. Romano. Any questions for Dr. Romano? If not, could I have a motion for approval of the credentialing action items?
So moved.
We have a motion. Do we have a second? Second from Dr. Stewart. All in favor?
Aye.
Any opposed? Credentialing action items are approved. Jeannie, I'm sure you've got lots to report.
Like Nurses Week this week, a few weeks ago was Volunteer Week. And so I just want to officially thank all of you and the staff. We were treated royally, felt honored and appreciated by the donuts that came and the muffins and the baskets of this and cards and emails and thank yous in the hall, and then the fabulous lunch at the Marriott where you're all there. It just meant a lot to us to have you there, to have other members of the hospital leadership that we don't have the opportunity to cross paths with or meet or sit at a table and share a meal and a laugh. And so it was really nice. So thank you very much. And no, I did not have anything to do with the $20 in the lemon. I had
Still
nothing
trying to
to do
figure
with
out how you
that.
did that.
And then a couple weeks ago, we had that masquerade jewelry sale, and wonderful success. Thanks to the staff, the patients that came just straight from the lab, what's going on, and wanting to spend money, and great participation in the community and employees and all. So the Service Leagues Commission was $14,870.60, which was up $1,000 from last spring. And so everybody's excited, ready to come back in the fall to help the hospital and get ready for Christmas. So we're looking forward to that. So thank you, everybody, for participating. And then lastly, we had our Service League Scholarship interviews this week. Up there you'll see members of the interview panel. And one of the distinctives of our scholarship program is that we do face-to-face interviews. We had 15 applicants this year. 3 members of the panel are Service League board members, and then we were able to get 2 clinical people. One, Jan Proud in the center there. She's a special care nursery nurse, been here for 17 years, nursing for over 30. And then thanks to Dr. Romano, who got us in touch with Dr. Safaya, one of our wonderful vascular surgeons. Having these 2 clinical staff members sit in was a wonderful experience for the students, as well as for both of them. They were great interviewers, great encouragers, and I think they would both say that it was a wonderful experience that they appreciated being a part of. We had 15 applicants that were just all cream, and but out of that, after going through everything, ranking everybody and meeting them face-to-face and talking with them, they were able to get it down. We have 2 4-year scholarships that we're able to give. They're $1,000 renewable for 4 years, provided the student stays in the healthcare field and keeps their grades up. I can't tell you who won yet because Gail Tomita hasn't informed them yet, but totally worthy candidates. And I'd say you have to promise to go get your wonderful education and come back and work here, because not only do they have the head, but you can tell they have the heart. And so it was our honor to choose 2 for those renewable scholarships. And then we had a special one this year. Unfortunately, the mother of our previous second vice president last year, her mother passed away, and the memorials that were sent in for her mother totaled $1,800. And so we were going to offer a one-time $1,800 scholarship, but because it was so hard to choose just one more, what we ended up doing was splitting it. So we have 2 $900 scholarships that they were able to give as a one-time for 2 additional students. So again, thank you, Dr. Romano, for getting us in touch with Dr. Safaya. So next year, if any of you are asked to sit on this committee, take advantage of it, because you'll be so encouraged. There are such great kids out there. They really give you hope for the future. So that's it. Thank you.
Thank you, Jeannie. They are our future.
Oh, yeah. Yeah, they are.
Thank you. We'll move on to the medical staff report. Dr. Romano.
Thank you. At present, we have 526 total members, including the Allied Health. 399 of those are active and provisional active members of the actual medical staff, not Allied Health. In addition, we have in process 7 pre-applications, and in addition to the 4 applicants you approved tonight, 4 other applicants are currently in process.
Thank you. That's my report. The growing staff. Nancy, we've got the hospital calendar.
Let's start with the video, please, Joe.
Good.
past health promotions and outreach events. On April 10th, as part of the Washington Women's Center Evening Lecture Series, Dr. Nitun Verma, sleep medicine specialist with Washington Township Medical Foundation, presented on insomnia. 40 people attended. On April 12th, Dr. Alexander Saw, orthopedic surgeon, and Dr. John Dearborn, orthopedic surgeon, presented Don't Let Achy Knees Slow You Down, Osteoporosis and Knee Replacement. 148 people attended. On April 20th, Washington Hospital's Green Team, the City of Fremont, and other local Tri-City organizations organized the Let's Go Green Together event. This free Earth Day Education Expo raised environmental awareness and shared eco-friendly ideas with people in our district. Attendees were encouraged to learn about recycling and how to save energy. Approximately 500 people attended. On April 23rd, Christy Caracappa, Health Insurance Information Service Coordinator, presented on health insurance options. 66 people attended. On April 24th, Christy Caracappa, Health Insurance Information Service Coordinator, also presented on Medicare and durable medical equipment for the Better Breathers Support Group. 52 people attended. During the week of April 22nd, Washington Hospital celebrated National Volunteer Week by showing appreciation for the invaluable work that volunteers provide. Activities culminated with a thank you luncheon which took place on Friday, April 26th. Over 150 volunteers attended the luncheon. On Saturday, April 27th, Washington Hospital and Washington Township Medical Foundation participated in the YMCA Healthy Kids Day 5K Walk Run and Health Expo. Washington Hospital staff participated in the 5K Walk Run, and Washington Township Medical Foundation staff provided information on health services for children and families. Washington Hospital was a sponsor of this event. Approximately 80 people visited the Washington Township Medical Foundation booth. On May 2nd, as part of the Diabetes Matters series, Anna Mazzei, registered dietitian, spoke on meal planning, peaks and pitfalls of a vegetarian diet. 22 people attended. On May 7th, Washington Hospital stroke nurses participated in National Stroke Alert Day. Stroke centers across Alameda and San Mateo counties partnered with EMS agencies and fire departments in cities along the BART routes to raise awareness about signs and symptoms of stroke. Washington Hospital stroke nurses handed out stroke information at the Fremont BART station during the morning commute hours. The stroke awareness handouts highlighted the FAST acronym as an easy way to remember the signs of stroke and what to do. Stroke nurses provided information on stroke prevention to 600 BART riders. On May 7th, as part of the Stroke Education Series, Dr. Ravinder Kalan, neurologist, and Doug Van Houten, RN, presented Introduction Stroke and Risk Factors for Stroke. 16 people attended. Upcoming health promotions and community outreach events. On May 14th, from 1 p.m. to 3 p.m., Dr. Rakesh Safaya, vascular surgeon, will present on deep venous thrombosis. On May 17th, from 12 noon to 1 p.m., as part of the Washington Women's Center's Lunch and Learn series, Alicia Davis, certified yoga instructor, will speak on fall prevention and balance. On May 18th, from 10 a.m. to 4 p.m., Washington Township Medical Foundation will participate in the City of Fremont Recreation Department's Kids and Kites Festival. Washington Hospital is a sponsor for this event. On June 4th, from 6 p.m. to 8 p.m., as part of the Stroke Education Series, Dr. Ash Jain, cardiologist, and Doug Van Houten, RN, will present Acute Management of Stroke and Chronic Care and Stroke Rehabilitation. On June 6th, from 7 p.m. to 8 p.m., as part of the Diabetes Matters program, Sandra Murdestorff, RN, will present On the Road with Diabetes, Traveling with Diabetes. On June 7th, from 9:30 a.m. to 1:30 p.m., Washington Hospital will participate in the Four Seasons of Health Expo. On June 10th, from 6 p.m. to 8 p.m., as part of the Washington Women's Center Evening Lecture Series, Alicia Davis, certified yoga instructor, will present on Neck, Back, and Beyond. The Washington Hospital Healthcare Foundation Report. The Foundation Golf Committee is working hard to ensure a great day of play for golfers at the Washington Hospital Healthcare Foundation Golf Tournament, being held at the Black Hawk Country Club in Danville on June 24, 2013. The tournament, named in memory of longtime Fremont businessman Jean Angelo Pisano, raised money to support hospice care and surgical services. To sponsor the tournament or to reserve your foursome, please call Washington Hospital Healthcare Foundation at 510-791-3428. The Washington Township Healthcare District Board of Directors Report. On April 18th, Washington Township Healthcare District Board members Patricia Danielson and Dr. Bernard Stewart attended the Newark Chamber of Commerce's annual State of the City address given by Mayor Al Nagy. On April 19th, board members Patricia Danielson, Dr. William Nicholson, and Dr. Bernard Stewart attended the annual Fremont Prayer Breakfast. On April 19th, board member Patricia Danielson attended the New Haven Schools Foundation's annual Pathways to Success Scholarship Luncheon. At the luncheon, Ms. Danielson presented the Washington Hospital Healthcare System Scholarship to Mary Favela, a senior at James Logan High School, who will be attending University of the Pacific in the fall. Mary is a longtime volunteer at Tri-City Health Center. On April 23rd, board member Patricia Danielson attended the swearing-in ceremony for Demetria Schaefer, Chief of Alameda County Fire Department and past president of the Washington Hospital Healthcare Foundation. On April 25th, board member Dr. Bernard Stewart attended HERS Breast Cancer Foundation's annual People with Purpose Luncheon. On April 27th, board members Patricia Danielson and Dr. Bernard Stewart attended Citizens for Better Communities' 21st Annual Spring Celebration. On May 3rd, board members Patricia Danielson and Dr. Bernard Stewart attended the Friends of Scouting Leadership Breakfast. Washington Hospital Employee Association, WIA. The Washington Hospital Employees Association received 9 applications for the Don Pickenpaw Memorial Scholarship. This $2,000 scholarship is available for dependents of Washington Hospital who are enrolled as a full-time senior in a California high school or are pursuing a degree as a half-time or more student at an accredited college, university, or vocational school. The winner to be announced in late May. On Saturday, April 13th, WIA held a theater excursion to Jersey Boys. 31 employees and family members attended the event. Washington on Wheels, WOW, Mobile Health Clinic. During the month of April, the Washington on Wheels Mobile Health Clinic, WOW, continued to serve community members at the Fremont Senior Center, the Family Resource Center, the Silliman Activities Center in Newark, the New Haven Adult School, and the Ruggieri Senior Center in Union City. The WOW Clinic also provided health care services to students and families at Briar Elementary School and Irvington High School in Fremont. WOW also provided occupational health pulmonary function testing, physical exams, and OSHA questionnaires to 30 employees at Exelitas Technologies, a global technology company. In addition, WOW provided 42 pre-employment physicals for those working at Tesla Motors in Fremont. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was April's most viewed webpage with 15,573 views. Other active sections include InHealth, Channel 78. During the month of April, Washington Hospital's cable channel 78, InHealth, aired new programming, including 2 Diabetes Matters programs, Protect Your Heart and What's New Diabetes Update for 2013. InHealth also taped the April Board of Directors meeting. For more information on any of the programs mentioned, visit WHHS.com or call 1-800-963-7070.
Thank you, Nancy.
My eyes readjust for a minute. I have a few items that I wanted to add on to the calendar section. There's been a report released. I put a copy of it in the board's binders. It's in Health Affairs, and it is an article that delves into the slowing rate of healthcare spending. It's a pretty interesting article and identifies a number of possibilities associated with it beyond the simple issue of an economic recession. One of the ideas that I found particularly interesting was the idea that a lot of the initiatives, such as the IHI initiatives that later became core measures, actually had something to do with slowing spending in healthcare. And that's an instance of something that we embraced fully, actually yielding significant patient benefit in terms of reducing rates of hospitalization and lengths of stay. As we addressed some of the issues around infections and medication errors and all of those things. They also talk about shifts that have occurred in who's paying for health care. And about 15% of the non-elderly population has moved into insurance arrangements that pay approximately 25 to 40% below that of private coverage. And utilization by the uninsured is considerably lower than that for individuals with private coverage. So they're suggesting that the coverage distribution had remained constant. The annual growth rate from 2000 through 2010 would have been higher by as much as 0.5 percentage point. But they say that there was a decade-long decline in real incomes and a shift from private to public coverage that reduced provider revenues. So we're trying to begin to understand some of the cutbacks. It's easy to turn to the changes that are coming from the Center for Medicaid and say that they bear the full responsibility, but there's some other very interesting dynamics involved in this. Some of the measures in the Affordable Care Act are being also credited with a reduction in healthcare spending. In 2014, one of the most important parts of the Affordable Care Act is scheduled to go live. And in California, we were notified today that they have delayed the implementation of the CalMedi Connect service, which is the dual eligible demonstration project, scheduled to go live on October 1st of 2013. And they are now saying it will occur no earlier than January 1st of 2014. So it's one thing to write the law, and it's another thing to make that elephant dance. It's a lot more complicated than people think. I also wanted to call the board's attention to an impending labor action, once again, at the East Bay Sutter facilities. This time it will be a 7-day strike, and it will involve registered nurses at Sutter hospitals in Alameda, and Contra Costa counties. It begins on May 17th, and it ends at 7 a.m. on May 24th. The 7-day walkout will include Alta Bates, Summit, Eden, San Leandro, and Sutter Delta. Yes?
I heard today that they expect Sutter to lock them out after the strike.
Yes.
So it will continue perhaps.
It has to do with how they bring in fly-ins. And they deliberately chose 7 days because in order to cover the 7 days, Sutter would have to bring in 10 days' worth of nurses and incur the expense for additional 3 days. And I think that's, it's playing with the number of days for which you must contract when you're bringing in a strike-breaking force.
Nancy, do you know if it covers any of the hospitals south of us?
No, it's Sutter East Bay.
Just the Sutter East Bay.
I know that the hospitals to the north and to the west have settled their contracts. And I think part of the dispute, as I understand it, and I'm not close to this at all, so I could be wrong, is that those contracts were settled without significant takebacks. And for some reason, Sutter is treating the East Bay differently. That's what SEIU would tell you. I don't know what Sutter's side of the story is. So we're off and running again. And this time, be 7-day strike and 10 days worth of fly-in nurses. One of the other things that's come up with regard to the Affordable Care Act is that as of May 1st, only 16 of the states in the United States, plus the District of Columbia, approved the expansion of their Medicaid programs. 27 of the states have rejected it, and there are 7 states that are still on the fence, but at this late date, it's literally too far gone on the calendar for them to become involved in time to operate something on January 1st of 2014. And finally, I have some positive news. Dr. Jane, cardiologist on our staff, was chosen to participate in a controlled trial with Abbott Vascular Absorb Biosorbable Stents. That's a mouthful. We're one of 35 sites in the country that were selected, and it's a drug-eluting absorbable metal scaffold that allows controlled drug release, followed in time by absorption of the drug carrier layer structural disintegration and bioabsorption of the scaffold. And so we're one of a handful of hospitals across the country that will be participating in that study. And it's an honor and a distinction for Dr. Jane and for Washington Hospital.
Very good.
And finally, I'd like to recognize Melody Pack. She's our Employee of the Month. She was hired in 2002 as a Central Reg Clerk, and she realized that her true calling was for caring for patients, and she decided to become a respiratory therapist. She went through the Career Ladder program at Washington Hospital, and in 2005 she graduated from Maloney College as a respiratory therapist and is dedicating her career here at Washington Hospital. Over the years, she's played a key role in the night shift with her strong sense of communication and teamwork with the department and with other disciplines. Her colleagues say Melody has a huge heart in and out of the hospital and with patient care. She genuinely cares about everyone that she meets. As an RT, she exemplifies leadership in her bedside manner, assessment skills, and collaborating with others, all for the well-being of the patient. Every day, she gives 110%. This recognition award is well-deserved. So that's what her colleagues have to say about her. Outside of work, she's married with 4 beautiful children and balances both work and family evenly. On her free time and days off, she enjoys running and is expected to complete her first full marathon this summer. That's 26.1 miles. And they feel in her department that she's a huge asset, and they're very proud of her accomplishments. I'd like to congratulate Melody.
Yes, and certainly deserving of that. Thank you. Let's move on to our quality report. Stephanie? We're going to be talking about nurse-sensitive quality indicators.
Thank you, Dr. Nicholson. Tonight I'm going to be presenting the quality indicators for nursing quality for quarter ending December 2012. What are nurse-sensitive indicators? Because oftentimes you see that definition and you don't really know what it is. But the indicators are focused on structure of care. They look at staffing, they look at education, they look at certification. They also look at process of care, which is your assessment and your intervention. They look at care at the bedside. Most of these metrics are focused at the care at the point at the bedside. And it's very outcome driven. These are measures that nursing do have some control over. So let's go back and give a little background about it. The measures are used to show the impact that nurses and nursing care has on patient outcomes. There are two major databases that we use for this information. It's NQI, which is a national database of nursing quality indicators, and you heard about that previously from the previous presentation. And this is the database where we send our data. It's where even the magnet hospitals use to benchmark. So this is the premier database and best practice as it relates to nursing. And then we also use the NHSN, which is the National Health and Safety Network, which is the CDC database. And that is more for the infection control indicators. So for this report, the measures that we're going to be looking at are central lines, catheter-associated urinary tract infection, hospital-acquired pressure ulcer, patient falls, and restraints. So let's start with the central lines associated bloodstream infection. And the goal here is 0. We're always going to strive to have no infections. And anything that's acquired after the patient has a central line put in and within 48 hours, anything after that 48 hours, we own it in terms of it being hospital acquired. So let's take a look at the central line. I think for quarter ending December, we had 3 patients in critical care that had central line infections in that 3 months. This is an initiative, an ongoing initiative for the hospital as it relates to central lines. It's very prevalent in critical care, and there's also a group in med-surg that's working on it. And you see this is one of the areas that we really need to focus on. Oftentimes these patients have multi-system failure, but the fact is that we need to try and prevent these infections. Catheter-associated urinary tract infection, and these are patients that have a Foley catheter placed. A culture needs to be done before the Foley catheter or when it's inserted. If it's not done and 2 days later that patient develops a urinary tract infection, then it's attributed to the hospital. Anything 48 hours after the device has been placed. And when you look at it for critical care, we are above the benchmark in terms of what NQI is as it relates to critical care. For med-surg, we are better than the benchmark. But again, these are ongoing quality initiatives that are going on throughout the nursing care areas. Hospital-acquired pressure ulcer. This data is a snapshot. It's 1 day in a quarter where all the patients in the hospitals are assessed for pressure ulcer. This is not reflective of what we see on a day-to-day basis, and there are some pressure ulcer that are hospital acquired. But again, for this information, we were better than the benchmark for both the critical care and the med-surg area. But this is a performance improvement initiative that is very ongoing within the organization in terms of preventing pressure ulcer. This is one true indicator that nursing does have control over. Patient falls for quarter ending December, we were better than the benchmark in both critical care and med-surg, and these are falls with injuries. The goal is we do have an ongoing performance falls team that look and assess all the falls, look to see whether it's medication related, look to see what can be done differently. So we are always striving because the goal is 0 falls. So any patient that falls, there is an assessment that's done to see what can be done better and how can we prevent it in the future. For restraints, this is the first time you are seeing this indicator. This is an indicator that has been recently added that's required for magnet, and we're beginning to look at our indicators. For critical care, we were above the benchmark in terms of patients being in restraints. One of the definitions of restraint is that you cannot have all the side rails up. So if you have 4 side rails up, it is considered restraint. So there's a lot of work being done. There is a performance improvement team that looks at all the restraints and look for ways in terms to minimize the use of restraints. The same is true for med-surg. We're again looking to see what can be done differently. We use the low boy beds. There's many other things that we have used in terms of to prevent falls and restraints. So we're looking to see what can be done differently. We try the different gadgets out there in the community as well to see what other devices would work. So this is a work in progress in terms of trying to minimize the use of restraints. And this is also an indicator that CMS and Joint Commission monitors, because if a patient dies while they're in restraints, we need to see whether or not there's a correlation between the restraints and the death. So this is all of these indicators are ones that nursing do have control over, and we need to try to ensure that it's at a level that we can manage. And that's about it for the quality report. Any questions?
No, I have no questions. Thank you very much, Stephanie. Appreciate that. Chris Henry, Finances.
Okay, tonight we'll be reviewing Washington Hospital's financials and results of operations for March 2013. We'll move right into our operating indicators. Average daily census for March came in 28 lower than we expected in the budget at 176.6. We had 989 admissions in the month. We'd expected at 1,167. And our patient days came in 868 below budget at 5,474. Outpatient observational equivalent days for March came in at 362. We had budgeted for 279, so we continue to see a little bit of that shift from the inpatient to the observation days. Average length of stay for March was a little bit below budget at 5.35. We'd expected 5.43. Moving into utilization, the case mix index for the month came in at 1.507. We had 162 deliveries in the month, 5 below the budget of 167. Surgical cases likewise came in below budget at 355. We'd expected 410 in the month. This includes joint replacement cases that were 7 above the budget at 115. Our neurosurgical cases were 9 below budget at 13. And we had 9 cardiac surgical cases in the month, 1 above the budget of 8. PTCA procedures came in 15 below budget at 34, and our outpatient visits for the month came in at 8,598. We'd expected 9,837. Emergency room visits for the month came in pretty close to budget at 4,558. We had budgeted for 4,539. Moving into our productivity, March saw 1,332.4 productive FTEs and 164.5 non-productive FTEs to give us total FTEs 10.4 above the budget at 1,496.9. Our FTEs per adjusted occupied bed, which is our productivity measure, came in 0.67 above the budget at 6.34. And I think what you're seeing in that number is us starting to ramp up. I think we're less than 60 days for going live with Epic, so we're really starting to ramp up with that, and it's affecting our productivity. Moving into the financials, total patient revenue came in 5.8% below budget at $182,892,000. Our contractuals for the month came in above budget at 77.25%. We did see more government payers in the month, and we had about an $800,000 rack take back affecting that number in March. So we ended the month with net operating revenue about $5 million below budget at $41,954,000. Operating expenses for the month came in $1.5 million below budget at $42,783,000, and the drivers in that really were volume related in our supplies, purchase services, professional fees, and of course our provision for charity and bad debt was below budget due to the lower volume. So we end the month with an operating bottom line, actually a loss of $829,000. We'd expected a $2,789,000 gain in the month. Non-operating income for the month, about $150,000 below budget at $1,198,000, and the culprit there is a small unrealized loss on our investments of about $121,000. So we ended March with a total bottom line of $369,000. We'd expected about $4.1 million. Moving into our Financial Accounting Standards Board presentation, and again, this is the way the financial markets tend to look at our financials. Our operating loss stays the same at $829,000. We pull out our property tax revenue that's used for the servicing of our GO bonds and our unrealized loss on investments to come up with non-operating income from a FASB perspective of about $610,000 and a total bottom line pretty close to break even with slight loss of $219,000 for the month. So are there any questions on March?
I was just curious, Chris, about the rack audit. That seems like the second one in a row where we've taken a pretty big hit on that.
Yeah, and they've been chipping away during the year, and next month we'll come back and show you some numbers. It is something that all hospitals are experiencing. They're getting more aggressive. They're adding a fifth rack auditor to the field to focus on specific issues. So it's becoming a real factor, and it's happening to all hospitals across the region.
Companies are incented by a percentage of what's taken back by the feds. And you can appeal these, but it goes on forever.
Yeah.
Any other questions for Chris? Thank you very much, Chris.
Go ahead with the statistics for April. We saw 943 patient admissions in April that resulted in 4,802 days of care. Our average daily census in April was 160. This was lower compared to March, which was 177. The high and low ranged from 187 down to 122. The budget for April had anticipated 1,053 admissions and 5,712 days of care, and an average daily census of 190. So you can see we're going to be way off budget this month. We'll come in 910 inpatient days of care below budget. The outpatient observation equivalent days came in at 302. We had budgeted 251. And from last month's discussion, you'll recall that this is a mechanism by which Medicare secures inpatient care without paying for it for the patients, but also exposes those patients to the Part B liability. The outpatient observation days we just covered, the average length of stay for adults and children in April was lower than budget at 4.86. We had anticipated an average length of stay of 5.42. The preliminary information indicates that the inpatient revenue for the month of April amounted to approximately $127,979,000 compared to the budget estimate of $136,421,000. Of this amount, 55.8% was Medicare and 7.5% was Medi-Cal, for a total of 63.3% in government program revenue. terms of births, we had 146 deliveries in April compared to a budget of 151. April's deliveries resulted in 297 baby days of care. Our newborns totaled 149. On surgery, we had 401 surgical cases at the hospital. Our budget was for 343. So substantially over budget in surgical cases. This includes cardiac surgical cases that were 4 above budget at 14. Our inpatient surgical activity was above budget by 54 cases. Outpatient surgeries were above budget by 4. 589 cases were seen in the outpatient surgery center. They had a budget of 552, so they were also over budget in terms of activity. For the month of April, there were 368 cases seen in the cath lab, including 39 PTCAs. Total cath lab cases were lower than budget by 14, and PTCAs were lower than budget by 10. Inpatient cath lab procedures were 65 less than anticipated in the budget, while outpatient procedures were 51 in number higher than expected. In terms of non-emergency outpatient visits in April, we were 2.2% lower than the budget. We came in at 8,646. The emergency room recorded a total of 4,251 patients with a daily average of 142, and that was 87 below the budget, which had called for 4,338. I think it's one of the few months this year where that's the case. Washington, Warm Springs, Newark, Nakamura, and Ohlone Clinic saw approximately 3,460 patients during April. That was 568 fewer than we had planned. The total system and emergency room and clinic visits for April are 7,711 compared to a budget of 8,366. Full-time equivalents for the month of April totaled 1,517.6. This included 66.2 agency personnel. 63 of these 66.2 agency personnel are EPIC RN registry, and we've brought them in to cover patient care duties while our nurses are trained for the EPIC system. FTEs per adjusted occupied bed came in at 7.06. Our budget called for 5.98, so you can see the impact of our EPIC install. In summary, we had 110 fewer admissions and 910 fewer inpatient days than anticipated in the budget. Surgical cases were above budget by 58, or a 16.9% positive variance. Cath lab procedures were below budget by 14, or a 3.7% negative variance. Outpatient visits for April were 2.2% below budget. ER visits came in 2% lower than anticipated. Clinic visits for the month were below budget by about 14%. Our total paid FTEs are above budget by 46 FTEs for the month and above the last 12 months average by 64.3. Inpatient charges for the month were lower than budget by approximately 6.2%, or $8,442,000. Our outpatient charges are higher than budget by approximately $3,598,000, or 8.9% positive variance. Total hospital charges for April were below budget by 2.7%, or $4,844,000. On April 30th, there were 175 days cash on hand. The total days revenue and accounts receivable at April 30th was 56.22. The days revenue and accounts receivable excluding Medi-Cal was at 52.85. During the month of April, $2,209,168 of charges were approved or pending for charity assistance.
Thank you, Nancy. We'll move on to our action items. Dr. Stewart, you're going to present item A.
Mr. President, in accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to purchase the intravascular ultrasound integrated system for vascular imaging for the amount not to exceed $109,712. This equipment was not included in the fiscal year 2013 fixed asset budget.
Second.
We have a motion and a second. Nancy, you want to tell us about this?
This is equipment that is new. It provides an index of the functional severity of a coronary stenosis. And it's calculated from the pressure measurements that are made during coronary arteriography. And this would enable the physician to make an on-the-spot diagnosis as to what extent a given stenosis or a coronary blockage contributes to a reversible disease process. And it relates to the decision whether revascularization of the stenosis is warranted.
This is true. Not every narrowing needs to be dilated, and this equipment will help us understand whether a particular area of narrowing does need to be worked on or whether it can be left safely alone. So we have a motion and a second. Any discussion, other discussion? All in favor?
Aye.
Aye.
Any opposed? Motion passes. Item B.
Mr. President, in accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to proceed with the purchase of hardware, software, and implementation services for the data storage system for an amount not to exceed $349,398. This purchase was included in the fiscal year 2013 fixed asset budget.
Second.
Great, thank you. We have a motion and a second. Nancy, you want to tell us what data we're going to be storing with all of this? I think it's going to be a lot.
Yeah, a lot. We'll store patient information, business information, images such as CAT scans. We'll scan documents that we've scanned will be stored there. The equipment's provided by EMC, which is a well-known and highly regarded data storage and software management company. And they've already provided several data storage systems for us in the past. The storage will be installed in each of Washington Hospital Healthcare System's data centers. We have data centers in Fremont and Boulder, Colorado. Each site will add a new system designed to back up and reduplicate critical information. They cost approximately $73,000 apiece, so one for Fremont, one for Boulder. And in Sacramento, we will purchase and install additional capacity for the VNX disk storage system, and that upgrade's about $145,000. But with the advent of the Epic system, data storage is now a new commodity we have to acquire.
Any discussion? If not, all in favor?
Aye.
Any opposed? Motion passes. Do we have need for a closed session tonight?
Yes.
Okay, we're going to adjourn to a closed session. We're going to reconvene to open session and announce that no action was taken in the closed session. And there being no further business, this meeting is adjourned. Thank you.